A single payer plan would be a plan like Medicare for All, or the kind of plan that they have in Canada, where basically government is the only person, is the only entity that pays for all health care. Everybody has a government paid for plan, even though depending on which country, the doctors are still private or the hospitals might still be private. In some countries, the doctors work for the government and the hospitals are owned by the government, but the point is that government pays for everything, like Medicare for All. That is a single payer plan. I have not said that I was a single payer supporter because, frankly, we historically have had a employer-based system in this country with private insurers, and for us to transition to a system like that, I believe would be too disruptive.
We get the federal government to take care of its business. I happen to be a proponent of a single-payer universal health care plan. That's no reason why the United States of America, the wealthiest country in the history of the world, spending 14% of its gross national product on health care, cannot provide basic health insurance to everybody. And that's what Jim's talking about when he says everybody in, nobody out. A single-payer health care plan, universal health care plan. That's what I'd like to see.
Who is supporting the healthcare system? The blue pillars represent the amount of money spent on healthcare in one of three categories. Number one, commercial insurance through employers and individual insurance, $953 billion. Number two, the uninsured, $80 billion. Number three, people covered by Medicare or Medicaid, $891 billion. The red line represents the number of Americans covered under each of these categories. Even though the Medicare-Medicaid population only covers 24% of the population, 69 million, the expenditure for this population represents just slightly over 46% of the overall annual expenditure for all Americans. On the other hand, employer-provided insurance represents approximately 56% of the population, 174 million, while the expenditure is approximately 46% of the overall total. How much private insurance costs? Cost shifting is a hidden tax imposed when providers of medical care adjust the prices they charge to private insurance companies in order to offset losses from partial or non-payers. The two biggest cost shifters are the uninsured and government programs. The uninsured are an obvious problem because anyone, including illegal aliens, can show up at an emergency room and receive medical care. Providers have taken the Hippocratic Oath, promising to give care to those that need it. The government is not as obvious of a problem. Medicare and Medicaid have been reducing physician and hospital reimbursements for many years. This has caused a significant problem for the poor and senior citizens to be able to find doctors in many parts of the country that are willing to add these people to their panels. Many don't want to take the reduced reimbursements. Both of these have a significant impact on private health insurance premiums because private insurance is making up for these losses, which currently add up to more than 17% of premiums. If we could encourage both these groups to pay their way, it would not need to be paid for by private insurance. Most uninsured, not a crisis. We all hear numbers bantered about regarding how many Americans are uninsured. It is important that we look at these numbers to determine how many are really uninsured long term. The fact is that there is no one magic bullet solution for the problem of the uninsured. If there was one, we would have solved this problem long ago. Instead, we have to break the problem down and find solutions for the specific uninsured populations. Number one, 46 million uninsured. This translates to roughly 15% of the population. It is important to note that while the overall number of uninsured have risen over the years, it has risen at almost the same rate as the U.S. population. The actual percentage of uninsured has stayed constant at roughly 15% for more than 20 years. It's also interesting to note that this 15% number is also roughly the same percentage of U.S. drivers that do not have car insurance, despite individual automobile coverage mandates in 46 states plus the District of Columbia. Number 2, of the 46 million, 34% are currently eligible for some type of government-sponsored health insurance program and have not signed up. Imagine what we could do if agents were involved in the enrollment process, or if the premium assistance programs were more widespread. Number 3, 32% of the 46 million have incomes over $50,000 and have not purchased insurance. We can assume these individuals are working. Do they not have access to employer-sponsored coverage? Are they turning down employer coverage because of cost issues? Are they individuals who are self-employed and have trouble finding access to affordable individual coverage because of a pre-existing medical condition? Do they understand the financial value of health insurance coverage? We need to look more closely at this population and design private market solutions that best meet their needs. Number 4, recent graduates and others who are temporarily uninsured make up another 14% of the uninsured population. Often these individuals are uninsured for less than 90 days, and many have COBRA coverage available but choose not to elect it. Number 5, those who are actually uninsured for a long term, more than 2 years, represent only 20% of the uninsured population. In other words, the 46 million population can be whittled down to approximately 9.4 million Americans. Yes, this is still a concern, but do we really want to disrupt the current healthcare system when we are talking about approximately 3% of the total population in the United States? Guaranteed access, individual coverage. Overwhelmingly, there is access and choice in most states. The most market-friendly approach is a high-risk health insurance pool, shown here as the gold-colored states. These pools provide guaranteed access for people with high-risk health conditions. Arizona, Nevada, Hawaii, Delaware, and Georgia, the blue states, have no problem or regulations to guarantee access to individual market. District of Columbia, open enrollment plan offered by Blue Cross. Florida, high-risk pool is closed to new enrollment. Ohio, very limited open enrollment. North Carolina, just passed a high-risk pool Blue Cross Blue Shield used to serve as carrier of last resort. Michigan, Rhode Island, and Pennsylvania have Blue Cross Blue Shield serve as a carrier of last resort. I would like you to notice 2 states next to each other, Pennsylvania and New Jersey. New Jersey, along with the other red states, requires insurance carriers to guarantee coverage to individuals or community rate.